This conference will now be recorded.
Good morning. Very good morning. Today's class is about anemia, one of the most common topics, and it is of clinical importance than your academics. But yeah, you can get a question on this in your theory paper also. But this is mostly clinical significance. Okay. Yeah, it's more than 100. So yeah, now we can start up. Shall we start, guys?
Yes, sir.
Yeah, thank you. Yeah, just bear this. This will be a short presentation. Okay, not a huge one. Okay, this most of picks. Okay, we'll discuss more practical things than on theory. Anybody can read theory, right? Yeah. Sorry. Yeah. Yeah, coming to the definition, what is anemia? If somebody asks you, your examiner going to ask you or something, you just deal with this thing. Okay, anemia can be defined as a reduction in hemoglobin concentration, hematocrit, or the number of RBCs per cubic mm. See, either the number is decreased or the hematocrit. Hematocrit means, as the name suggests, it is blood has been settled. Okay, that is the count of the blood cells. Okay, hematocrit, and it is hemoglobin concentration. Whatever it has been reduced. Okay, that is anemia. And when you define anemia, it is not the same for all the ages and all the sexes. So it is like you have to demarcate the differentiation. So the lower limit of the normal range is set at a 2 standard deviation below the mean for age and sex for the normal population. Okay, this is the perfect definition. If you are going to define anemia, you need to define it as it is below the 2 standard deviation mean for age and sex. Okay, this is what anemia is, because numbers don't mean anything to us, because a 10 hb, okay, let's say a 11 hb is normal for an adult. It is not never normal for a newborn are supposed to have more hb, and so it is not the numbers that matters. Okay, that is the importance for this definition. Okay, anemia is historically it is derived from Greek word, like most of the names. It is loss of blood. Anemia means loss of blood. Okay, so this is all the definition regarding anemia, and this is a WHO differentiation of anemia and non-anemia. Okay, regarding the age group, set age group. Okay, children of 6 to 60 months of age, 110. Okay, this is in grams per liter. So just you put a decimal, it becomes the DL per gram per DL, because we do gram per DL, right? So just 11, just imagine that 11 and higher in a 6 months to 60 months kid is non-anemic, and mild, moderate, severe it is 100, I mean 10 to 10.9, and moderate is 7 to 10, and lower than 7 is severe anemia. Okay, likewise 5 to 11 years of age, it is 11.5 or higher is normal, 11 to 11.4 is moderate, mild, and 8 to 10.9 is moderate, and less than 8 is severe. 12 to 14 years, the same thing goes. It is more than 12 HB is good, and 11 point till 11.9 it is mild, 8 to 10.9 moderate, and less than 8. Okay, just these numbers, just remember these 1 point. 6 months to 60 months, that is up to 5 years, it is 7 or below is bad. Okay, for 7 to almost 15 years it is 8. Okay, it is 8 that is severe. And again in an exception is your pregnant woman, it is 7. Okay, less than 7 is severe. Okay, just remember this. For all other practical purpose it is 8, and for less than 5 years and pregnant it is 7. Okay, just remember this. All these numericals are blah blah stuff, you know, you can this is all academic, but just remember this. This is our interest, because see, mild is not just mild, like, you know, because see, what happens in anemia is your blood cells goes down, your hematocrit goes down, your hematocrit, and all the hemoglobin all comes down. What happens if all these things comes down is the basic functionality of the blood and the concentration of the hemoglobin will be affected. So what happens is your oxygen exchange gets hit. Okay, your delivery system of oxygen is damaged, because the prime purpose of hemoglobin or your blood is to transport and get in and get out of the oxygen and carbon dioxide. This is the main functionality of your blood, and that gets hit. So your job of delivering oxygen to the tissues gets hit, so that your tissues are not going to function properly, and your normal mechanism gets damaged. This is what happens in anemia. That is why we are concerned. If nothing is happening, we don't concern. And when we say that it is mild anemia, it is not mild anemia, because already your functionality gets hit, and then your numbers turns up. Okay, just remember that your symptoms comes first, like your irritability, fatigue, your muscle weakness, your uh, uh, pallor, and all these things comes first, and then your numbers show up, like after 10, like that. So mild is not just, it is just a number. Okay, the mostly we concern about the severity of the disease. Okay, just remember this concept. Mild, saying that mild anemia you should not treat, it is nothing like that. The child is already a symptomatic child, and only the number is saying that it is mild. Okay, so you may have to take care of the child in spite of these numbers of mild. Okay, the near normals, milds. Okay, this is the importance. Okay, that is what I want to stress upon. Okay, then now coming to the evaluation. Now there is child with anemia. You identified it physically. You identified a child by numericals. You got you ordered a CBP. You got your HB. You got your hematocrit. And so how are you going to come to the cause of it? Like what happens to it? Okay, the first step in diagnosing anemia is to know that whether the abnormality is an isolated red cell decrease, or is it the decrease of all the cells, all the cell lines. You must be knowing, or there are three cell lines. It is red blood cells, white blood cells, and the platelets. Okay, or the three got a hit, or is the only the red cell is going to is the one that got hit. Okay, now coming to the abnormalities of two or more cell lines, like all the cell lines are involved, or only two cell lines, or your bone marrow involvement. See, the bone marrow being the main the factory producing got hit. So the conditions are aplastic anemia, as the name suggests, aplastic. Okay, it is not producing. Okay, aplastic anemia and leukemias, they do a lot of production, but they don't do quality production. Like it is not the thing that we wanted. It just haphazardly gives out cells. That is leukemia. And an immunological disorder like connective tissue disorders, like your SLEs and other connective tissue disorders, and immune neutropenias and idiopathic thrombocytopenic purpura, ITPs. Okay, and immune hemolytic anemias, HUs, and all these things. There are two or more gets hit. Mostly your neutrophils, like your WBC and your platelets gets hit, or your RBC and platelets gets hit. Okay, like that. That is your immunological disorders. And then the another mechanism is your sequestration of the cells. Like if the spleen is hypersplenism, like it is doing more job than it has to do. You see your all the deformed cells and the cells gets uh, crushed up and in the reticular endothelial system. This is your spleen. So if the spleen is doing its job too efficiently and unappropriately, that is your sequestration of cells. It eats up platelets, it eats up WBC, or it eats up more of RBC and platelets, so producing two or more cell line damage. Okay, and now coming to the another possibility, that is, once the anemia has been established exclusively of red cell problem, like WBC are good, platelets are good, only the RBC are got hit. Like RBC count is low, or the hematocrit is low, or your HB is low. Okay, then we should think of two possibilities. Okay, one thing is the production from the bone marrow is good, or is the damage that is happening to the cells are more. Okay, there is only two possibilities. Okay, when the RBCs are decreased, I mean that there is an anemia, there is two possibilities grossly, whether the production got hit, or the functionality, I mean it is eaten up faster, or the production is low. Okay, now coming to the production low, is then is depressed RBC formation due to infactual erythropoiesis, in which the marrow has many erythroblasts and there is reticulocytosis. Okay, there is formation defect. In that there is two scenarios, like your bone marrow is producing more of erythropoiesis, like ineffectual, like there is more cells but they are not doing the job for you. Okay, this is a condition. This happens in your beta thal. You know, thal is known for it. It does ineffectual erythropoiesis. There will be a lot of cells but they don't make up to your job actually. So this is one condition. There will be more of reticulocytes, there will be more of our erythroblasts, the primitive cells in the bone marrow, but they are not going to do your job of oxygenation, carrying into the tissues. Okay, that is how your anemia works out in this. And there is another condition where in which there is a failure of erythropoiesis. The production itself is gone, and in that production gone, there will be decreased erythroblasts. The primitive cells of RBCs, the erythroblasts, are decreased in number in the marrow, and there is absolute erythroblastopenia, and there is reticulocytopenia. Reticulocytes, I mean, you must be knowing, right? This is from your our pathology. Reticulocytes are just one step behind RBCs, the mature RBCs. The one step behind is your reticulocytes, and 2 or 3 steps behind is your erythroblasts. Okay, that is how the evaluation of RBCs, right? The erythroid lineage from the bone marrow. I think you must be knowing it. Erythroid and myeloid series. Your erythroid lineage goes like this, right? Erythroblast, then goes into normoblasts, and then reticulocytes, and then goes into your immature RBCs, then into the mature RBCs. Only the mature RBCs get into the circulation. All the uh, uh, not many of these primitive, they get into the circulation. Yes, here and there few reticulocytes can be found, but these blasts, they set up in the bone marrow alone, but they are not going to do the job of the blood. Okay, so the another possibility is there is high destruction of the cells. Once the cells are produced into the circulation, there are more RBCs into the circulation, but they are not getting the job done because they're getting eaten up. Okay, they're getting consumed, like your hemolysis, or is there any ongoing hemorrhage, like chronic hemorrhages, like usually you'll see the peptic ulcers and GI bleeds. They will be unnoticed mostly. When the child constantly loses blood, the color of the stool is go darker, but nobody gives heed into the thought. Just but after a few months down the line, like that, the child suddenly presents to us with a lot of paleness, inactiveness, poor growth, and fatigable, and that is how we identify that there is an ongoing. Yeah, our presentation goes with more of tables. These are put wantedly because there's nothing much into this thing, but to just give a whole holistic approach. Okay, now the first topic is our etiology of anemia in children. That is why it occurs and what all conditions that can give us anemia to the child. Okay, that can give an anemia. Okay, this is the second part of our thing is your morphological classification of anemias. So once you know the cause, you know, how do you classify your anemias, like. Okay, now coming to the first topic, etiology. Like, what are the causes of anemia in children? Okay, either they are impaired red cell formation, the red cell formation itself is damaged, and that is giving you less hemoglobin, less hematocrit, less number of cells of RBCs. Okay, I'm repeating it again and again so that you just think of it. Okay, anemia means less RBCs, less hematocrit, and uh, okay, the deficiency of hemoglobin. Okay, yeah. Yeah, deficiency. Now, what all can decrease the production or impaired RBC formation is your decreased dietary intake. You see, if the raw material is low, you are not going to make up the product. It's something like that. Okay, the deficiencies. Okay, decreased dietary intake, excessive cow's milk. If there is excessive cow's milk is good in iron, but it is not so much well versed with iron that it can be absorbed. Okay, so there will be a relative iron deficiency anemia if you're taking more of cow's milk, and calcium also gets in between in the iron absorption. Okay, that is why they will say that don't take iron tablets along with milk, so that there will be fighting for the same receptors. Okay, so yeah, if there is a vegan or vegetarian, B12 deficiency, because most of the source of B12 is from the animals. Yes, it plants do give B12, but not much. So it is mostly the animal production. Okay. So that is your raw material deficiency that is giving to your anemia. And there is increased demand. For example, there is growth, you need, there is rapid growth, this adolescent period, and there is bodybuilding, like muscle mass is increasing, and there is a lot of bone changes happening. So body do need more of iron and other minerals, and if we are not meeting that demand of growth, then we can get anemia. Okay, then there is hemolysis of, obviously hemolysis happens when there is a folic acid deficiency. That is your yeah. And there is decreased absorption. We I think we must be knowing, yeah, intrinsic factor which helps in the absorption of B12, this pernicious anemia, atrophic gastritis, and all these stuff, they get hindered. The absorption gets hindered during in the gut. Okay. And generalized decreased absorption is in malabsorption syndromes like folic acid and iron deficiencies. Okay. And impairment in RBC formation can result from one of the following deficiencies. Okay. This is a small table which is showing you the um, diagnostic feature in the deficiency. Okay, in case of iron deficiency anemia, there is a hypochromic. We'll discuss all these things, all the terms, but I have kept it here so that we'll discuss the etiology mostly. Hypochromic microcytic red cell. Yeah, here I'll tell. Hypochromic, chromia is color, hypo is less. Okay, less colored, micro small, cytic cell, less colored small cell red cell. Okay, that is what it means. Okay, so it is small cell, so the volume should be low, so MCV is low, and color is low, so hemoglobin should be low, so low MCH and low MCHC also. It is the titering of this. And yeah, and high RDW means red cell distribution width. Like if there is distribution with, you just remember that if they're all more all the sizes, you see the normal diameter is around 7 microns, the RBC 6 to 11 microns. If the distribution of the size of the RBCs are from smaller to bigger, that means that there is high RDW. If the distribution is only to particular part, like only 7 microns or more, only 10 microns or more, that is your low distribution width. Okay, remember this, because in thal it is important, because in thal your RBCs are more or less of the same size. Okay, that is how we differentiate between iron deficiency and your thal. In iron deficiency, there will be different sized RBC, small to bigger at a different proportion. But in thal, it is monotonous. It is mostly one set of diameter of the RBCs. They do stay there, and that is your low RDW. Okay, red cell distribution width, RDW. Okay, yeah. In iron deficiency anemia, yes, the ferritin levels, the storage product is low, and there is a high ferritin products and guaic positivity. You see, this guaic test is for the cultivate in the stool. That is, there is a filter paper, and you just smear it and you get it. Okay, just remember the name guaic. Okay. And folate deficiency, as we discussed, there will be hemolysis actually. Yeah, macrocytic red cell, macro big cell red cell. Okay, so the volume is more, so your MCV should be high, and similarly there will be high RDW, because from a normal cell to bigger, there will be a lot of distribution. So high RDW. And in the cells, what we see is your megaloblastic. The blasts are more in size. See, whenever you say blastic, mostly the blast cells are in the bone marrow. Okay, so megaloblastic marrow, and low serum folate levels or RBC folate levels, as the name suggests. So the same thing goes with your B12 deficiency. And vitamin C deficiency produces scurvy. Scurvy, perifollicular hemorrhages, petechiae, and all the stuff is with your scurvy. Yes, scurvy can produce anemia. Just remember that. Protein deficiency, like protein energy malnutrition, kwashiorkor produces anemia. And B6 deficiency, where there is hypochromic RBCs, less colored RBCs, and sideroblastic bone marrow, and high ferritin levels. Okay, all these things Remember that the ferritin levels are high in B6 deficiency, so there is less colored, but ferritin is more. So you should think of not iron, because in iron your ferritin levels are low. Okay, there is another cause that is causing the anemia, so that is B6. Okay, and thyroxine deficiency or hypothyroidism produces anemia. Okay, and yeah, coming to the another, after deficiencies, the bone marrow is not functioning properly and producing your RBCs. Okay, so now there is a condition called only the RBCs got hit, or your WCBC got hit, or your platelets got hit, only the single cell line, or all the lines got hit. Okay, there are two possibilities. Now coming to the platelets, megakaryocytes. See, a megakaryocytic thrombocytic purpura with absent radius. This is TAR syndrome. And diagnostically you can see that absent radius, your limb abnormality will be there, the radius is not there, so there will be ulnar deviation of the hand. And thrombocytopenic purpura, as the name suggests, it also has purpura because thrombocytes are also got decreased. And red cell, there is a diamond blackman anemia. There is only the RBC precursors are lost. The myeloid series is very good, the platelets megakaryocytes are good, only the RBCs got hit. This is congenital. It is in diamond blackman syndrome, anemia. Just remember the name, some fancy examiner can ask you. Okay, and there is acquired RBC aplasia, where there is erythroblastopenia of the childhood. There is term called TEC, transient erythroblastopenia of childhood. It is very transient. I mean, it gets corrected by itself, nothing to worry. But in that, we will see that there is RBC cells are decreased. The rest of the lines are good. Now coming to the congenital neutropenias, where the WBC gets hit, there will be obviously neutropenia and recurrent infections because there is decreased RBCs. Okay, and now coming to the failure of all the cell lines, like pancytopenia, that can be congenital or acquired, your Fanconi's anemia and dyskeratosis congenita. These things can produce all the cell lines defect with the bone marrow itself is hit. Okay, and acquired, you take it can idiopathic aplastic anemia, idiopathic, we don't know why the bone marrow doesn't produce anything. And okay, the secondary causes, whether there is infection that is causing bone marrow depression, there is drugs or the radiation causing bone marrow depression, there is toxins that causing bone marrow depression. The infections, remember, parvovirus B19 is notorious for it and to hitting the bone marrow and causing all the lineage defects. And HIV, yes, it can cause. Okay, now coming to the infiltration, yeah, they are leukemias and lymphomas, your benign like osteopetrosis and storage disorders like your Wilson's and other Niemann-Pick's and Gaucher's. These the products, the storage products, they sit in the bone marrow and doesn't allow the bone marrow to produce the cells. Okay, that is benign cause, like benign in the sense it is not malignant. Okay, yeah, malignant causes like your leukemias and myelofibrosis, where your bone marrow aspiration will tell you the story. Okay, the secondary causes, like the source is somewhere else than the bone marrow. That is the meaning of secondary. The sources may be in neuroblastoma. There is a big tumor sitting in your adrenaline adnexure, and yeah, and lymphomas, your VMAs, your vinyl methylene acids in the urine, they get increased, and yeah, bone marrow examination has to be done. And dyshemopoietic anemias, like anemia of chronic disease, your TVs can produce, your SLEs and all these things can produce. Okay, there is decreased production, okay, in this. And renal failure or hepatic failure, and disseminated malignancies, tissue disorders, and sideroblastic anemias. In sideroblastic anemias, remember, there is a hypochromic, color will be less, and there is ring sideroblast. Okay, this is something important. And now coming to the other possibility. See, first of all, we thought the bone marrow itself is not producing or getting used up. The other possibility is there is using up of the already produced blood. That is either as a hemorrhage, the blood goes like occult blood, like WAC test and all, we can do it. There is a blood loss, or there is a hemolysis. The blood red RBCs are produced, but RBCs are getting eaten up by in the circulation. Okay, either they are eaten up in the as corpuscularly they are eaten up, or extra corpuscularly they are eaten up. Okay, now coming to the corpuscular, the cell itself is of defect, and the cell membrane is damaged. That is the shape is not good, that is spirocytosis or elliptocytosis. Once the shape is not good, they don't get squeezed into the sinusoids of the spleen and they get hemolyzed. So your spleen gets enlarged because of doing overwork, and then the hemolysis will produce jaundice. Okay, this is the clinical features to identify that there is okay, there can be a defect in the corpuscularity. And there can be enzymatic defects like pyruvate kinase G6PD deficiency that will produce autohemolysis after taking stress fever or taking some drugs. They get stressed, RBC gets stressed because the enzymes are not there. Your pyruvate kinase is not there, G6PD is not there. So because of the stress, the cells get break down, and the same thing, jaundice and hemolytic picture we can get. And there is another cause like your hemoglobin itself is a defect, where the production of heme is bad or production of the globin is bad. Where the quantitatively, if the production of globin is bad, that is your sickle cell, you can find it. And if the quantitatively, if the global chains are not there, the beta chains are not there itself. In sickle cell, alpha is there, beta is there, but it doesn't do the job of the thing. That is qualitatively the globulin chain is defect, and quantitatively the number itself of globin is not there. That is producing your thalassemias. Okay. Okay. Now coming to the other causes like extracorporeal. The corporeal is, as the name suggests, it is the RBC itself. Okay, the enzyme of the RBC, the membrane of the RBC, or the contents of the RBC, like your heme or your globin, that is causing the defect. Now, extracorpuscular, the RBC is good, but something else from outside is eating up the RBCs, like your immunity or non-immune. Like in immune, isoimmune, your Coombs text is positive. In isoimmune, there are antibodies against your RBCs that is eating up, and autoantibody like idiopathic secondary causes of your lupus, SLEs, and other conditions that can produce. And non-immune, non-immunologically, they can be idiopathic. You never know, but the cells don't do the job of this thing. Okay, or secondarily. Okay. Then coming to the other morphologically, because our class is morphological classification, so we should know the terms. Microsites, small celled RBCs, can be seen in iron deficiency, thalassemia, lead poisoning, and anemia. This is table from Nelson. You can get it easily. Yeah, this is one place where you can get all the cells in all the types in one place. Okay, just I'll read down so that macrocytes, big cells, new ones, that is normal because the cells are produced from the bone marrow and they just drop into your circulation. Okay, B12 and folate they can produce, and diamond black fan where red cells are aplastic, they'll produce the uh, precursors. All the precursors are bigger in size, so they'll produce it. And Fanconi's anemia, this is something like aplastic only, aplastic anemia itself. So liver disease, Downs, and hypothyroidism. Remember, hypothyroidism gives macrocytes. Okay, this is your entrance bit actually for your NEET. In what type of anemia you see in Downs and what type of anemia you see in hypothyroidism is your macrocytes. The cells will be bigger. Okay, then spirocytes, like there will be spherical, round, good shape. The hereditary spirocytosis, this is inherited cause, and immune hemolytic anemias can produce spirocytes, and hypersplenism can produce spirocytes. Okay, and sickle cell, obviously sickle cell disease. You know that Valen goes, vitamin goes and Valen welcomes. Okay. And elliptocytes, that is something like just like your spirocytes, there is hereditary elliptocytosis, and iron deficiency anemia can also produce, and megaloplastic anemia. Anything can produce elliptocytes. And target cells, remember there is a hemoglobinopathies produce target cells. Your thals and sickles can produce target cells. Target cell is like the bullseye target, the dart target, like okay. There is a dot inside a circle. That is your target cells. We will be seeing the pics following. Okay. Liver cell can produce target cells, and basophilic stifling, this is basophilic stifling of the RBCs. Remember that basophilic stifling of the RBCs. Okay, they can be present in your lead intoxication, myelodysplasias, and TALs. Okay, RBC, fragmented RBCs are called as helmet cells, Burr cells, and all these things are different types of RBC fragmentation. And DAC you can get, and HUS you can get, uremia and liver diseases, Kasabak Merit syndrome, where platelets are also low. Okay, These are the TTP, thrombocytopenic purpura. You can get fragmented RBCs and hypersegmented neutrophils, like neutrophils, not the RBC, but neutrophils are hypersegmented. You can see in B12 deficiency and folate deficiencies. Okay, and blast cells, as we discussed, if the blasts are supposed to be in the bone marrow, if they're overproduced, they will be thrown into the circulation, and you can collect them in the circulation. And those, the conditions which will result in more production of blasts is your leukemias, severe infections, and leukopenias, Fanconi's anemia, aplastic anemia, where the blasts are more. In these conditions, the blasts are more, but the mature cells are less. Okay, and whole jolly bodies seen in spleen, asplenia, hyposplenia, and severe iron deficiency anemias. Okay, remember, severe iron deficiency anemia can give Howell Jolly bodies. Okay, that is a thing. This is also an entrance this thing. Okay, uh, okay, these are the conditions of the different shapes, and now these are the pics showing different cells. Megaloplastic, as the name suggests, big cell megaloblast cells. And iron deficiency anemia, there is a hyper color is gone and the cell size is gone. Okay, oh, so first of all, we'll see this is the color and size of a normal RBCs, that is in the center. And here iron deficiency anemia, color is gone, it has faded, not red, it is like orange color, and the size is also decreased, that is your iron deficiency anemia. Megaloplastic anemia, the size is increased compared to the normal cell, that is 7 microns. It can go up to more than 12, 13, 14, and the color is the same, right? Okay, now coming to the hereditary spirocytes, the shape is not no more discoid or biconcave, it is like a globe, like a 3D ball. Okay, there is hereditary spirocytes, the color is the same. Okay, and hereditary erythrocytes, the color is the same, that is normochromic, normal colored, but the shape is not discoid, but it is like more elliptical in shape. Okay, here the color is gone, hypochromic, and the cells wall is gone, like acanthocytosis, there is spiking, this is seen in Burr cell, this is helmet cell, this is helmet cell. Okay, RBC fragmentation, this is helmet cell, this is Burr cell acanthocytes. The color is gone. Important point is the color is gone. Okay, hypochromic. And sickle also, the color is gone. Okay, and the shape is the sickle shape. Okay, and this is the target sign which we are discussing about. The color is gone, hypochromic, and then there is the accumulation of all the hemoglobin into the center of the cell, that gives your target sign. Okay, this one pic gives you a lot of comparative things. Okay, the color gone and the shape and sizes are gone. Okay, this is important in this. Okay, yeah, now coming to the some factors. Now coming to the factors, now we have discussed about the morphology, like what all can happen to the shape and sizes of the RBCs that can give rise to anemia. Now coming to the hematocrit value. Some places where the hematocrit can raise. Okay, your polycythemia, kidney problems and heart problems because of continuous anoxia and anemia, there will be more production, apparent more production in heart diseases. And intake of anabolic steroids producing, and dehydration, the plasma gets decreased, but the cells are the same, so they'll give apparent increase in hematocrit. Okay, hematocrit, you must be knowing, right? Your Wintrop's centrifugation and all these things, we must have done it, or you guys must have done it in your pre and clinics. Okay, and diarrhea is something like dehydration, your plasma gets decreased, so the number of cells gets apparently increased, so that gives a raise in hematocrit value. And lung problems because of chronic hypoxia, there could be more cells and raise. Burns, the same thing, your dehydration producing more concentrated blood. Smoking produces stimulates the bone marrow to produce more cells. Okay, that is smoking. And high altitudes is the same thing, a lot of ambient anoxia, decreased oxygen in the atmosphere, that will give you more hematocrit. Yeah, I have put this picture to depict it. You see, this is the normal hematocrit 45, this is the RBCs, this is the plasma. Okay, this is what 100% should constitute. In anemia, as the definition goes by, your RBC count is low, your hemoglobin is low, Okay. So the base has come down, the main material has come down, but the plasma is taking care of the rest of it. Okay. Now in case of polycythemia, the over of a thing, the opposite of anemia, your RBC is more and your plasma is getting compromised. The total 100, the plasma getting compromised, and there is more of RBCs. Now in case of dehydration, what happens is your RBC is the same. Okay, your RBC is the same. There is no loss of your red cells or hemoglobin or any other thing. Your RBC is the same, but what happens is your plasma gets decreased. There will be loss of free water in either by burns or your diarrhea, vomiting, whatever it is, your fluid is gone. So in the total of 100, you will get an apparent increase in hematocrit. Okay, like 70%. That doesn't mean that there is more of RBC. It is a normal RBC, but the plasma is low. Okay, this is a tricky situation, so I have put this slide so that you can understand it better. Okay. And now coming to the indices, why indices is because only because by these indices we can morphologically classify our anemias. Okay, it is mean corpuscular volume. Corpuscle is your RBC, and volume, the volume of RBC. What it means is defined as the average volume of RBC. It provides information of the size. It is measured in fact femtoliters. Normal range is 90 to 85 to 95 and 90 base. Okay, it is femtoliters. Femtoliters is like 10 to the power of minus 15 is femto. Okay, that is the thing. And cells of normal size, that is 76 to 96 is the normal value, are called normocytic, and smaller are microcytic small cells and larger are macrocytic. Okay, 76 to 96. How do you calculate it? The formula, it is your hematocrit by RBC count, hematocrit percentage by RBC count in million. Okay, that gives your normal range of 76 to 96. And these are the conditions. This is the morphological classification. These are the conditions that give you the see hypochromic microcytic. The cell size is low and the color is low. So when the size is low, when I'm saying that the size is low, the volume is low. If the, how do you say that the volume is low? Your